This meeting is now being recorded.
Hi, my name is Christi Dougherty, and the title of my capstone is The Impact of Communication Competency Training on Nursing Students' Self-Advocacy Skills. The members of my committee were Dr. Heidi Landry as the chair, Dr. Barbara Pate, and Dr. Helen Reed. I will start with a brief overview of what I wish to speak about for the next several minutes. The focus of my project was on the self-advocacy beliefs and behaviors within the nursing student population. It was an implementation project that included a communication competency educational intervention entitled Team Steps. The project was quasi-experimental in design, utilizing one group of participants that completed a pre-test and a post-test. The problem that I had identified was that the current format for teaching self-advocacy and communication skills in the associate degree nursing program did not promote practical application of skills. Nursing students need experiential training to enhance their ability to participate effectively in crucial patient and self-advocacy conversations. In other words, if they believe something is wrong, students need a tool to speak out. The background and foundation for this project is based on the challenging responsibilities of nursing in today's complex healthcare environment. According to the definition and scope of nursing practice, nurses must protect patients and demonstrate advocacy in the care of individuals, families, communities, and populations. Nursing students must be prepared to make decisions, solve problems, and be patient advocates. They must be empowered to address dangerous shortcuts, incompetence, and disrespect demonstrated by colleagues. They must be committed to reducing errors, improving quality of care, and promoting a work environment where all members are valued and engaged. This impacts nursing because communication skills are needed to effectively advocate for patients. Research indicates that few nursing students feel empowered and prepared to confront physicians, nurses, or educators when these controversial situations arise. Many lack the communication skills to influence and skillfully collaborate for their patients. It is vital, therefore, for nursing educators to provide students with a method for implementation to effectively advocate for patients. This begins with giving students a tool to advocate for themselves. With a dedicated framework, students can build confidence in their ability to advocate for themselves and their patients. The purpose of the study was to implement and evaluate the effectiveness of utilizing a portion of the Team Steps curriculum in an associate degree nursing program to increase self-advocating behaviors in students. A nurse can be competent and caring, but without adequate communication skills to speak up, patient advocacy is threatened. Enhancing nursing education to provide an implementation format that teaches nursing students how to open a dialogue with other healthcare professionals is vital for patient advocacy and self-advocacy. It was my hope that data obtained from this project could enhance nursing education, engagement, and patient care. The project question was, is there a difference in self-advocacy behaviors and beliefs in nursing students following an educational competency program related to communication competency? The theoretical framework for this project was from Malcolm Knowles' adult learning theory. Knowles' model, seen in this diagram, is based on 6 core assumptions about adult learners. First, the adult need to know. 2, the self-concept of the adults to be responsible for themselves. The previous experiences of the adult learner. The learner's readiness to learn. The orientation that the learner is task-centered or problem-centered. And the learner's motivation to learn. This framework was well suited to guide this project with a focus on the educational component. The adult nursing students were taught the scope and standard of nursing practice, which illustrated the need to be patient advocates. The learner's self-concept and previous experiences enhanced their ability to see the value of obtaining the skills of effective communication in professional nursing. Additionally, introducing the communication techniques, including role-play scenarios and group discussions, enabled students to see the problem-centered focus of the educational presentation. The impact of effective communication skills on their ability to promote self-advocacy and patient advocacy in their nursing careers was effectively demonstrated, lending value to the educational experience. My literature review was divided into three components that supported the need for the project. The three areas were patient advocacy, self-advocacy, and communication. In regards to patient advocacy, the Code of Ethics for Nurses describes the professional responsibility for nurses to advocate for the rights of patients. As an advocate, the nurse must be alert to and take appropriate action regarding instances of incompetent, unethical, illegal, or impaired practice by any member of the healthcare team. In other research, specific behaviors were described which demonstrate a nurse's patient advocacy role, including communicating the patient's rights regarding medical treatment, healthcare delivery, and informed consent. In regards to self-advocacy, the National Student Nurses Association outlines in their Code of Academic and Clinical Conduct the responsibility of nursing students to self-advocate. It describes the responsibility to work in safe environments where they are competent to practice and prepared for their assignments. The environment should be conducive for students to learn and, if necessary, to voice any safety or practice concerns without retribution. There's also the expectation that students should not accept or allow behaviors that threaten the safety of themselves or their patients. The Cusin Institute identifies competencies required in the preparation of future nurses. Within the teamwork and collaboration competency is the required skill of a professional nurse to assert his or her own position and perspective in discussion about patient care. In regards to communication, the Agency for Healthcare Research and Quality, during their development of the Team Steps curriculum that was utilized in this project, identified the importance of communication in complex environments such as healthcare, describing effective communication skills as needed to convey clear information, provide awareness of roles and responsibilities, and explain how performance impacts outcomes. The importance of effective communication has been outlined in the data published by the Joint Commission related to sentinel events. Sentinel events are characterized by the root causes or fundamental reasons an event has occurred. The second leading cause of sentinel events behind human factors are communication failures. Finally, research provided evidence that strengthening communication in nursing education was an essential requirement for quality nursing practice. Conflict resolution skills were considered a critical element in working with other healthcare professionals. The project was a quasi-experimental comparative research design encompassing an educational component and a pre-test, post-test survey questionnaire. The survey was completed by one group of nursing students, immediately followed by the Team Steps educational intervention. Then 2 weeks later, the survey instrument was again to be completed by the students. Comparing the results of the two surveys allowed evaluation of whether the outcomes had changed after the provided intervention. The educational intervention was purchased from the Agency for Healthcare Quality and Research and was developed in collaboration with the Department of Defense Patient Safety Program. It focuses on skills and concepts that provide specific tools and strategies for improving communication and teamwork, reducing chance of error, and providing safer patient care. Components included in the educational program were the assertive statement, the two-challenge rule, and the CUS technique for voicing a concern. The presentation included PowerPoint slides, viewing of video role-play scenarios, and group discussions. I received permission to utilize the Nurse Workplace Scale survey instrument designed by DeMarco, Roberts, Norris, and McCurry. The Nurse Workplace Scale measures non-self-advocating behaviors and beliefs of nurses and provides a tool to measure behaviors in nurses that are counterproductive in the workplace and oppress a nurse's ability to effectively advocate as an individual and as a group to contribute to the healthcare system. The survey consisted of 12 brief statements that ask how often the respondent has experienced the possible behaviors, feelings, or beliefs. Choices are selected based on a Likert scale of 1 to 5, ranging from never to always. Examples of the behaviors are ever preface statements with phrases such as, I know this is a really stupid question, constantly comparing yourself with others, or complained about a problem to your fellow workers but did nothing to confront the person you believe is causing the problem. The instrument in its entirety is located in the appendix of my capstone paper. The reliability and validity of the Nurse Workplace Scale was analyzed using Cronbach's Alpha and the student's t-test, respectively. The Cronbach's Alpha value for the full 12-item Nurse Workplace Scale was 0.81. Validity of the scale, assessed using the student's t-test, displayed predicted patterns of mean differences, which argued for subscale validity. Therefore, it was substantiated that the reliability and validity of the nurse workplace scale was acceptable, consistent, and valid for use. The scope of the project involved a convenient sample of sophomore associate degree nursing students from Trinity Valley Community College located in Kaufman, Texas. The inclusion criteria was that all students were enrolled in a single course, RNSG 2573, called Healthcare Concepts 3. All students were expected to participate in the Communication Competency Educational Intervention. However, those students who chose not to participate in the survey were excluded from data collection. I chose this course because although I am an instructor at PVCC, I had not taught any prerequisite requirements for this class and was not involved in any lecture components or assignments of grades in the course. A few limitations of this project should be noted. First, the study was dependent upon the willingness of the participants to honestly answer the survey questions regarding self-advocacy attitudes and behaviors. In addition, the size of the participant pool was a maximum of 138 students registered for the course. Also, the time frame was 2 weeks between surveys. The study received Institutional Review Board approval by both American Sentinel University and Trinity Valley Community College. The sophomore associate degree nursing students were approached for participation. An informed consent, demographic survey questions, and the nurse workplace scale were distributed. I read the purpose, objectives, and potential benefits of the study, all included in the informed consent to all prospective participants in attendance. I allowed for a period of time for questions to be voiced. Once questions were answered, I left the auditorium. Then the participants completed the survey, and the designated proxies collected the packets, sealing the results in an envelope with a signature over the seal to maintain integrity. Afterwards, the educational program began and included PowerPoint slides, video presentations of role-play scenarios, and group discussion. 2 weeks later, the Nurse Workplace Scale survey with an attached paper asking for the student's name was distributed and collected by proxy. A proxy removed all individually identifiable information, assigned random identification numbers for each paired survey, and placed signed consents and participant name pages into a sealed envelope. Completion time of the survey was approximately 15 minutes. The educational program lasted approximately 1 hour. No deviations were made from proposal data collection methods. To protect the rights of human subjects, I made sure the students were informed about the purpose, objectives, and methods of the study. They were told that their participation was voluntary and that they could withdraw from the study at any time. Those who agreed to participate signed the informed consent. Anonymity and confidentiality of results was protected. No student was excluded from participation, and there were no repercussions for choosing not to participate. This project did not pose any identifiable risk to participants. All survey data was entered into a password-protected computer. All paper forms are being maintained in a locked file cabinet. At the end of 5 years, all paper data will be destroyed by incineration or shredded, and all computer files will be permanently erased. Analysis was conducted using the IBM Statistical Package for Social Sciences, SPSS, version 22. The independent variable was a communication competency training. The continuous dependent variable was obtained by totaling the ordinal responses from the nurse workplace scale. Descriptive statistics were performed on the demographic data and evaluated using frequencies and proportions. Total scores from the nurse workplace scale, time 1 and time 2 independently, were evaluated for central tendency, variability, and normality of distribution to confirm that no assumptions were violated, which require a non-parametric test to be utilized to answer the project question. A paired sample t-test then evaluated the differences between two same group means at 2 points in time. Finally, power analysis and hypothesis testing was performed. A total of 138 sophomore nursing students were registered in this class, but attendance was not mandatory. At the initial survey and educational competency intervention, time 1, 100 surveys were distributed and 75 returned, resulting in a 75% response rate. At time 2, 62, or 82.7% of these students completed the survey. The decrease in responses may have occurred as a result of absence or attrition in the project. While this posed a threat to internal validity due to non-response bias, the sample size was sufficient to overcome potential differences in scores that may have occurred if all participants had completed both surveys. One of the students submitted an incomplete nurse workplace scale at time 1. Thus, this result could not be included in the study since complete survey total scores were utilized for analysis. A total of 61 participants answered both surveys, yielding an overall completion rate of 81.3%. Most of the participants were female, between the ages of 26 and 34, Caucasian, spoke English as their primary language, had some college credit or an associate degree, and were not the first in their family to attend college. In order to utilize the parametric statistical paired t-test, my next step was to evaluate 4 assumptions. The first assumption evaluated was level of measurement. Each of the parametric approaches assumes that the dependent variable is measured at the interval or ratio level, that is, using a continuous scale rather than discrete categories. As I stated, the ordinal responses obtained from the Likert-type instrument were added to create the continuous dependent variable of total scores. Thus, this assumption was met. The second assumption to be evaluated was homogeneity of variance. Parametric techniques make the assumption that samples are obtained from populations of equal variance. In the paired t-test, variance is low because of the correlation in pre- and post-measurements inherent in the design of using the same individuals. The third assumption was the evaluation of normal distribution. A distribution is said to be normal when both measures of skewness and kurtosis fall between -1 and +1 range. The values fell within this range for time 1 and time 2. Additionally, research states that with large sample sizes, over 30 participants, the violation of this assumption does not cause any major problems. The sample size in this case was 61 participants. The histograms with overlying normal curves displayed here demonstrate the normal distribution. Finally, the fourth assumption was that observations were independent. The study did not involve any observational data acquired singularly or in a group. Therefore, with the assumptions being addressed, it was determined that the parametric paired sample t-test was appropriate to answer the research question. The paired sample t-test was used to analyze the difference between the group mean scores at time 1 pre-intervention and time 2, 2 weeks post-intervention. There was a statistically significant decrease in nurse workplace scores from time 1 with a mean of 29.1 and a standard deviation of 7.44 to time 2 with a mean of 27.25 and a standard deviation of 6.332. The t-value with 60 degrees of freedom was 2.766, and the p-value was 0.008 two-tailed. The mean decrease in the nurse workplace scores was 1.852, with a 95% confidence interval ranging from 0.513 to 3.192. The eta-squared statistic was 0.113 and indicated a medium effect size. The conversion of eta squared to Cohen's d resulted in a 0.71 or medium effect. Next, I performed hypothesis testing, checked for type 1 and type 2 errors, and performed a power analysis, all of which are detailed in my paper. In brief, the null hypothesis in the study was that there was no difference in students' self-advocacy scores pre- and post-participation in the communication competency educational program. The alternative hypothesis was that there was a difference in students' self-advocacy scores following the intervention. Since the p-value of 0.008 was less than the level of significance, or the alpha level, which was 0.05, the null hypothesis is rejected. Additionally, the 95% confidence limits were 0.513 and 3.192, indicating that the actual difference in the pre-test and post-test means had a 95% probability of lying between these two values. Since 0 does not lie within this range, The null hypothesis can be rejected, and the alternative hypothesis was accepted. A post-priori test utilizing G-power found that this study had a 78% chance of detecting a significant effect at the p.05 level when one really existed. So what does all this mean? This project demonstrated that communication competency training significantly decreased nursing students' non-self-advocating beliefs and behaviors as measured by the Nurse Workplace Scale with a medium effect. The high response rate for the survey means that this project is likely to produce similar student outcomes under similar environmental circumstances. Malcolm Knowles' adult learning theory was the appropriate theoretical basis for this project and contributed to the significance of the results findings by building on the principles regarding adult learning. First, adults need to know why they need to learn something. The nursing students were reminded in the educational program of the professional responsibility for patient and self-advocacy. The PowerPoint slides in the Team Steps curriculum outline the patient care issues that could occur if a nurse was not prepared to advocate for a patient's safety or voice their own concerns. Secondly, according to Knowles' theory, the emphasis in adult education is on experiential techniques. The video presentations in this project displayed scenarios of communication ineffectiveness. Group discussion immediately after watching the videos allowed for participants to make suggestions for improvements to solve the problems identified. Congruency between this project and the Team Steps curriculum is demonstrated by the utilization of the adult learning theory in both educational programs. A fundamental responsibility for professional nurses is the ability to skillfully advocate for patients and themselves. Nursing students must have the necessary communication skills to influence patient care outcomes, collaborate with other healthcare professionals, and handle controversial situations. Without adequate communication skills to address concerns, advocacy is threatened. This project applied a segment of the Team Steps curriculum to a pre-licensure associate degree nursing program. To the best of my knowledge, though highly successful in clinical practice settings, this program has never before been utilized for nursing students. It is the responsibility of nursing educators to provide students with the best available tools to enhance patient and self-advocacy skills. The Team Steps program, specifically the focus on communication, advocacy, and assertion skills, provide a foundation for learning, participation, and reinforcement of those necessary advocacy skills. Implementing the Team Steps curriculum in nursing education provides nursing students with formal training to guide the process of communicating concerns to affect patient safety. This study's significance and positive impact on society is evident. Patients in healthcare settings are vulnerable, relying upon the support of nurses to advocate their needs and desires, thereby easing their transition through the healthcare environment. A caring, competent nurse equipped with communication skills necessary to advocate for themselves and their patients is vital. One recommendation for future research is to replicate this project. Replication is essential to substantiate significant results, determine generalizability within different demographic characteristics and geographical locations, and to further expand on the findings. Reproducing the study in other regions and in different levels of pre-licensure students can be studied. Additionally, collecting follow-up data at scheduled intervals could determine if the significant self-advocacy results were maintained over time. Also, initiating a longitudinal study with the educational content leveled to the academic progression of the student would reinforce the material and perhaps produce a larger effect. Repetition of the active learning techniques could be expanded into experiential scenarios in the simulation laboratory. This learning model would require students to build on their knowledge of self-advocacy communication skills to actively address controversial situations with other healthcare providers. Finally, incorporating a qualitative component into the study, then completing a mixed method project design could contribute insights into the development of advocacy skills in nursing students. qualitative data, such as open-ended interviews that provide actual words of the people in the study, could offer many different perspectives on the study topics and provide a complex picture of the situation. In summary, patience and self-advocacy skills are required for professional nursing practice. Nursing students need to be prepared to advocate for their patients and themselves. This requires communication skills to influence and skillfully collaborate in crucial situations. The data in this project indicated there was a statistically significant decrease in non-self-advocating beliefs and behaviors following participation in the communication competency intervention as indicated by the student scores on the nurse workplace scale. Utilizing Malcolm Knoll's adult learning theory by clearly outlining the value of the education to an adult student's professional practice and incorporating experiential techniques of learning was instrumental in the positive outcomes. Overall, the results indicate the significance of providing communication competency education to nursing students and the positive impact on students' ability to advocate for themselves and their patients, which influences the delivery of health care and the improvement of patient safety. Thank you very much for viewing my presentation.